Hello, Royal Stoke Resource.
Ready to go? Cardiac arrest, 5 minutes.
X-ray. Hello, Resource.
We've got trauma in 1.
1, 2, 3.
Oh, that's...
I think we'll keep that on, actually, to hold the dressing.
We've been caught on the hoof a bit here, and this gentleman's now just dropped his blood pressure quite significantly.
Ouch.
Where's that hurting? Chest hurts, okay.
We have to make sure that we get the clot out quickly because it can cause death to the patient.
Royal Stoke Resource staff nurse, can I help?
Maricel, patient's here. Okay, Asher, first thing I want you to check when we're in the cubicle is for a pulse, please. Do we have a pulse?
Can't do that, yeah.
Can't feel a pulse. Start chest compressions, please.
Mental rate of 26.
Carry on chest compressions if you cannot feel a pulse.
Ready, steady, slide.
Okay, Julia, straight back in, please. No. Asher, just leave it for the minute. Okay, you've just done a pulse check. That is groaning associated with every compression. He's not taking a breath, and we didn't have a pulse. Okay, he is breathing. Okay, stop. We have breathing. Stop chest compressions. We have signs of life. He is taking a breath. Does he have a pulse? Can we check in the groin, please, as well, Julia? We have a pulse. Okay, let's stop there and listen to handover. Keep a hand on that pulse, please.
What we're doing is buying that patient time. Every decision you're making for that patient is trying to slow that clock down. Hold on to that second hand, drag it back. Because if we did nothing, that patient is dead.
Right, 70-year-old male seen to collapse in the street.
Yeah.
Passerby got to him, checked the pulse, no pulse, commenced BLS.
Yeah.
We got to him, he was VF arrest.
Yeah.
Shocked him. He's had 4 shocks with us, and he's had good CO2 readings throughout of 5.
Fine. Lovely, thank you. So, let's start at the top end. Airway-wise, what do we have?
We got an oral airway and he's got a patent airway at the moment. I can't
Okay.
hear any groaning noises or anything like that.
Given conscious level then, can we prepare for intubation? Yeah. Okay, have we got a radial pulse?
Yeah.
I have a radial pulse.
You have a radial pulse. Okay, so we've got a radial pulse. We don't have a AAA. Can we get an
Irregular.
Okay, can we get an ECG machine, please, and see what rhythm we're looking at? Disability-wise, how are we looking?
He's not making any noises at the moment. He's not opening his eyes.
Yeah.
I've got a jaw thrust on, which is quite painful, so he's not responding. So I say GCS3 at the moment.
GCS3 pupils?
Pupils are dilated but reacting.
Dilated but reacting. Okay, so we've got GCS3 but equal and reactive pupils. Pass me a green. Have we got a green cannula?
If someone's arrived in hospital in cardiac arrest, the moment you've got that pulse back, no longer are you dealing with a dead patient who you're trying to bring back to life. You're dealing with a live patient you're trying to stop dying.
We're frothing at the mouth, aren't we? So, can you take that to the gas machine and run it straight away for me, please? So we've got access now. Jay, can you grab the checklist for the crash RSI, please? Okay, we're going to go for a crash RSI. Do we need any more help?
Yes, please.
Okay. This man's just had his life saved by the paramedics. So we need him to now try and work out why he's collapsed. The most common cause of this, that's the wrong tubing rear, the most common cause of this is going to be something going on in the heart, such as having a massive heart attack. At the minute, all this guy's got keeping his airway open is a plastic tube that's just holding his tongue out the way. Given the fact he's unconscious, he's not protecting his airway, we need to try and get something in so that we can keep the airway open. So we're going to pop him off to sleep and paralyse him. This is quite a dangerous thing to do in the position he's in. Okay, IV access, we have an IV in the right ACF, we've got left IO. Suction working?
Yep.
10mm syringe?
Yep.
Lovely, thank you. ECG? BP?
ECG's on the BP.
Blood pressure?
Blood pressure we got.
SATs,
Yeah.
defib.
Yeah.
Brilliant. What drugs are we going to use? Induction agent.
Just a bit of propofol and rocuronium, please.
Okay, we have adrenaline. Do we have metaraminol?
We are getting that ready.
Okay, and atropine?
Atropine's ready as well.
Okay, we've gone through the checklist. Tell me when you're ready. It's quite a nervous point in this, doing this. Just prep for sedation. You know that the chance of survival of any cardiac arrest is very low. If someone's arrived in hospital having had it in the street, the chance of them leaving hospital are 2%. And it's a frame of mind that you have to enter. So we have no CO2.
Good.
We have CO2.
Thank you.
Okay, let's secure that. Okay, what's the echo look like?
Looks like he's had a
He's got a scar on his chest. He's got a scar on his legs. That would suggest he's had previous heart surgery.
Another squeeze.
How are we looking on the severe LPs? Cardiology registrar is giving him an echo looking at how the heart's functioning, and from that he's saying the left side of the heart, the main pumping chamber, isn't working very well at all. Severe dysfunction, so it's not really generating the sort of flow it needs to be able to keep everything going.
Quick roll and then have a listen to as well. Plug it in.
So it's all about stabilising, finding out the causes so he can get the appropriate onward treatment. He's had life-saving treatment already.
Unknown.
Let the cardiologist make their plan. Get in bed for him on ITU.
Okay, are they coming by land or air?
Porter to resource, please. Your code red, thank you.
Hi, it's Ben. I'll come through in 2 minutes.
And what's your ETA? Bye.
Excellent.
This is Dave, the 27-year-old gentleman who was possibly attacked with a machete. It looks those sort of wounds to the left side of his head and the right side of his neck. Was just found in a big pool of blood and was loaded onto the ambulance by the time I got there. Airway secure and we're happy. Yeah. I'm not going to get a lot out of here. I've got about 4 mils. Right, it's 2 sharps on the patient. Just getting rid of them. Actively bleeding or not? Do we know if tranexamic acid's been given?
I think we'll keep that on actually to hold the dressing, and we don't know where that's gone through. So this man has got potential C-spine injury with that.
Oh, hey there. Yeah, you. We're talking to you? Ooh, what's this? What conditioner is this? They're all talking about Aussie 3-Minute Miracle and its rawsome conditioning. That's when Aussie tames your mane, taking it from dry to gorgeously conditioned in just 3 minutes. Wow. Now, bragging is not our style, but it's no wonder Aussie's the UK's #1 conditioning treatment. Have you tried it yet? Rawsome conditioning from Aussie. Grab yours now at Boots.
As a skincare expert, I love
My 5.
There's been a report of inappropriate behaviour between your
5.
Okay, so airway's fine, breathing we're good, and we haven't got a pulse oximeter, but we're ventilating okay. We've just had a blood pressure read at 68 and there's no fluid or blood up yet. Right. And so we need to think about getting some blood products up, I would have thought.
Yeah.
Just got to get that scan done, otherwise we're not going to know what we're dealing with, are we?
In a major trauma centre, your thought process is, what immediate life-threatening injuries has this patient got?
Jose, could you fill in a form for a full body CT? Sorry, I just need other things doing whilst I'm on the phone. And go and tell them that we need a full pan scan, hyposensitive, big laceration to neck. This is going to need a senior decision maker to look at it. Into one, please. Could you ring Kamath for me?
I was thinking, what do I need to do now for this patient? Who do I need to help me?
Gentleman in A&E who has an extremely deep laceration to the right side of his neck.
It's not unusual to have 4, 5, 6 consultants involved.
Do you have a registrar you could contact or your consultant?
And all the time the clock is ticking.
Okay, so what lights we got in at the moment?
We've got 2 greens at the moment.
Okay, fine. I want a blood pressure when we actually scan him to see if any... At the moment, he may not be bleeding because he's not got a blood pressure. Can we make sure we take some C-locks around there in case he starts hosing out of his neck?
X-ray.
Okay, he may have aspirated on that right side. He's quite patchy changes.
Yeah.
There's no obvious pneumothorax on there. Thank you. And the blood's on its way down, is it? We've been caught on the hoof a bit here, and this gentleman's now just dropped his blood pressure quite significantly, so we're getting blood into him immediately. The risk of doing that is that when we put his blood pressure up, he starts bleeding out of his wounds. But if we scan him with a low blood pressure, we may not actually see where he's bleeding from. So this gentleman's critical.
We're quite hypothermic, and whether or not we've had other contusions or anything else going on with
Well, I'm concerned that he's got an intracranial bleed going on, and I'm concerned that when we get his blood pressure up, he bleeds either from his neck or his head.
Yeah.
Can we get a log roll and just check his back, because we will look really silly if we've got a laceration to the back. Again, not bleeding. So, John, you're taking head?
Yeah, absolutely. So
just keep an eye on that neck on your right-hand side.
I've got my finger kind of on it. 1, 2, 3.
Okay. Take all the clothing out, please, as well, Jose. Pull it all out.
Large laceration to the left side of his head, scalp. No injuries that I can see to the back, starting to bleed from the laceration on the head.
Check round his buttocks for wounds and things.
No wounds seen.
Okay. So what they used to do in Manchester is get you down and stab you in the arse.
Empty rectum, no bleeding around.
And no blood in it. No, lovely.
We can't do anything without a surgeon who's saying we're going down there, but we can phone CPOD and find out. We'll do that while we're in CT. Okay, we're ready whenever they are. Let's go. Belmont's coming with, yeah? Okay, should we start going? Transfer bag's coming with.
I'm sorry.
Thank you. We're coming straight up, guys, so we're going to need space to get through, please. Silver trolleys there for ventilation. You saw it in vent, Dave?
Could you run round to ED and tell them that as soon as the blood arrives, we need it here?
Okay, but we'll go side a smidge more.
Fantastic, lovely.
Perfect.
This gentleman's very critically ill. We've got him to a point that we can get him into CT scan. It would be very easy to go, this is isolated to head and neck, that's because he's obviously bleeding from there, but we don't know what's going on inside.
You're wondering, what am I going to find now? What is going to change when we see this scan?
Whoa! This man's got a massive intracranial bleed. Okay. Should we go right turn down to theatre?
A right turn is as serious as it gets. Everyone knows what it means. It means that patient's best chance of survival is to be in an operating room.
Okay, we're coming straight from here. They need to be ready in 10 minutes.
Yeah.
Apart from neck, we've actually got no other bleeding points, have
No, but we need to make sure he's not got a spinal injury as well before we start fiddling with anything as well. Because if they've chopped down to that degree, it could have, it's nearly a decapitation, isn't it?
Yeah.
Initially, you think, oh, this is all blood from the outside. But when you actually put it into 3D, there's a picture showing where the slice has gone through the side of the head. On this view, there's the fracture through the skull, and this white area is blood within the brain tissue, and this is from the slice going in here. He's got damage to his brain tissue from this. So what the outcome is going to be, we don't know.
The injury to the neck has missed his major blood vessels. If that injury was just a tiny bit deeper on the front, he would for sure have been dead when we found him. He's extremely lucky. I mean, he was this close to death.
I've done everything I can for that patient, and now I'm handing them over to someone else to do what they need to do.
Okay.
Can I pass you over?
Hello, it's Chris Pickering, trauma team leader. Okay, so hit by a car. Yeah, landed on left side, injuries to head, hand and chest, you're saying?
We're just a bit stuck for hands, I think.
That'd be most useful. Cheers, thank you.
Because we've got a hit and run, we're coming on in. Wonderful, thank you, bye. Darren's coming to help you.
The longer it takes, you start thinking, right, How long have I got?
Is this one?
What am I facing?
Yes, this is the gentle one.
What's the mechanism?
RTC, we'll go into 1, please.
Do you want to have one? You have one. Stop.
Is it going to be sick?
Yeah.
Okay, let's roll. Hands on. Get a bowl, please, Asher. On roll, ready, set, roll.
Just behind you.
Suction on, please. What's your name? Jess, can you turn the suction on, please?
Then you strap down here. We've got you. You okay?
Chris.
Any more?
Satya, I'm in the middle of a trauma holding someone who's vomiting. Come to resus, but I'm not in charge. Bye.
Oh, all right.
Just suction in his mouth, please. Just suction in his mouth. Where you can see. Okay. Okay, happy? Let's go back down. Unroll, ready, set, roll.
So this is 70-year-old Paul being hit by a car approximately 40 miles an hour. He has a contusion to the top of his head. He's got quite a few lacerations as well. Blood pressure is 185/93.
Okay, cool. Right, let's just do a primary survey then, please, Asher. Just...
Take deep breaths for me, Paul. Yeah.
Again.
Asher, can you visualise down that left-hand side? Because they were saying there was down in actually in the axilla. Get those clothes out of the way and let's see what's going on. It's fine. Just move on, Asher. Okay. Long bones. There's quite a lot of blood around.
These clothes off, yeah.
Where's that hurting?
Where it hurts, babe?
Just the chest.
Your chest.
Chest hurts.
Ouch.
So, what I want to do, guys, is I want to get this chap through the scanner. Okay. It's pouring, is it?
Not get through the scanner.
Asher, have a look at that headwind, please. See why we won't get through the scanner with it. He's been hit by a car, so let's get a pressure bandage on that, please. Yeah, so.
Can you lift that arm at all, sir?
There's a big bruise on his
So the arm's a bit of a mess, his head's a bit of a mess, he's repetitive, he's got C-spine pain, but it's the chest pain as well. So he needs to we'll get him a code red and then see where we're at. All right, cheers. Hello. I've got a gentleman in A&E resus who has been hit by a car. It looks like he's sustained a significant head injury of some sort, and his left arm is quite a mess as well, and there's active bleeding coming from that. So he's in resus 1. Cheers, thank you.
Do you
Bye.
want to give some fun?
Yeah, give him some analgesics, yeah.
Okay. Where are we going?
Go into that CT
Oh, the
scan.
machine, all right.
Have a look at your head.
I'm always impatient to get to CT because it gives you so many answers.
Ready, steady, roll.
CT used to be called the donut of death because when you've done that stabilisation, when you've got them ready, it's going to be the place where you find out what's going on.
20 to 20.
Right, no catastrophic bleed. Let's get him off and let's get him back. I mean, he was run through as a trauma, query confused, query skull injury, they were querying a chest injury. He's getting a couple of stitches in his hand and he's broken his big toe.
You're not able to get up? Okay, fine.
But we have to keep mounting that response to be able to make sure that those that do come in seriously injured get looked after properly.
So they were all crying when I walked
Royal State Resource.
She's been taken off NIV.
Okay, have you spoken to the stroke team at all? Thanks, bye. Okay, we've got 4 minutes for a stroke. Stroke team are aware.
Bye. He's got a very high stroke score. It's on the right side and he can't speak, so it's a severe stroke.
Thank you.
Hi.
Hello, Steve.
Hi.
Hello. Has it been... Nice to meet you.
Okay.
Look at me, Steve. You see my finger here? Can you follow my finger with your eyes? Can you try and lift this leg up for me? Put it up for me. Keep it up. Okay. Try and lift it up again for me. Steve, lift this leg up.
Dashed up here so fast, I don't even know where I am. It's all a massive shock. It just happened so rapidly. So rapidly. 1 minute he was all right, and the
Try and lift
next.
this arm up for me again. Give it a go.
Still reeling from it, really.
Okay, we've got a tense hemiplegia. He's pretty much aphasic.
So he can't move any of his right side. He's completely weak, can't speak. So you're very serious here.
He wasn't very well this morning, and I thought he suddenly went to sleep. And I joked about, why do you know, you've gone to sleep and I'm talking to you, so jokingly, am I that boring? And I could just, he suddenly went very rigid. And then his right arm was dragging down the side of the bed. So I just ran downstairs and phoned for an ambulance.
Steve's got what we call a large vessel occlusion.
Yeah.
One of the bigger vessels are blocked.
Yeah.
What we do is take Steve to the theatre,
Yeah.
okay? Use a small tube, go through the groin, into the blood vessels, go all the way up to the brain, try and suck the clot out. All right?
Yeah.
We'll do what we can. In terms of the risk, we might not be able to remove the clot at all. That's a possibility. We might, whilst trying to remove the clot, accidentally rupture the blood vessel. There's always a chance that he might have a cardiac arrest.
Yeah.
All right? I mean, these are
Yeah, I know you've got to tell me.
expected complications that I need to be talking to you about. Okay?
He'll be fine, don't worry, okay? I just need to talk to you quickly, just a second.
Yeah.
Without the procedure, the chances of survival is less than 50%,
Yeah,
okay?
yeah.
We can't give you guarantees, but with this procedure, at least he has a hope. Okay,
Yeah,
he may,
thank you.
and he may do well as well. Let's go. Right, so we're going to take you down for the procedure now, okay? He'll be okay. Strokes are time critical. Every minute you waste, you lose millions of brain cells. It's always about getting it in time. He's got a severe disabling stroke. There's a chance of death and disability. Also, he's got no speech. It's a pretty grim situation for the patient, and also his wife was very distressed to see him that way. So we'll see what we can achieve in this particular case. You've got the catheters ready? Once the procedure itself starts, the number one priority is to make sure that you get the clot out quickly.
Written consent, or was it consent form?
Oh, it's consent form.
Okay.
There is a saying that time is brain, because every minute you lose, you're losing a lot of brain cells.
In requirements all being met, are we justified?
Yeah. Because we access the patient from the groin, all the arteries connect to each other, or the blood vessels. So from the groin we go to the neck, and from neck we access the vessel in the brain. We go to the clot, capture the clot and take it out.
And any critical or potential unexpected step?
No.
Thank you.
Let's go. Okay, neuron max. Okay, the wire is okay. Okay, just pull back the wire, please. In these procedures, there is a very small margin for error. Right. Because you are in a brain vessel, and it's like every movement is like a few millimeters. Yeah, that's enough. That's enough. A little bit of error can cause a huge brain hemorrhage, or it can cause death to the patient. Okay, that's the occlusion.
So there's a clot lodged in here, and it's obstructing the flow of blood into this left side of the brain. And what the consultant is doing right now is taking a catheter up through the site of occlusion, deploying a stent. The clot would then get embedded in the stent. The stent will be pulled out, and this whole area of the brain will be recanalized, reperfused, and blood will flow in.
Okay, let's do a run. Okay, lose the roadmap. Wait, don't open it as yet. I'll see if I can do it without that. I need a, not this type of syringe, I need a manual 50 ml, please. A proper, yeah. We got the clot. Yeah, it looks like quite a bit.
So that's the stent remover which we had used, and that bit over there, that's the clot.
See the pieces of clot, which 1, 2, and then we have another piece here. This is a clot which flew from some part of his body, like from his heart, and this has gone to the brain and caused this occlusion, the major occlusion of his vessel. So we have managed to take the clot out and open it up. This is only, we have to find out what's happened. Yes, everything has opened up nicely. You can see clot's gone, the brain's opened up nicely. Okay, we are done. We'll see how he goes. He has to recover from the anesthetic.
Stephen? Hello there, my name's Karen, I'm one of the nurses. You squeeze my hand.
It takes up to 7 days for the brain cells to actually just to adjust itself after having such a severe insult. So we'll see how he goes now. There is a bit of anxiety here when you are waiting to see how the patient reacts. Human brain and human body itself is a puzzle. Every patient reacts differently, and you realize every time you think you have understood the aspects of this procedure, then you realize that you're back to square one where everything seems a mystery.
Stephen, it's doctor's here to see you.
How's he doing?
He's moving his left hand side, he's still not moving his right side.
Hello, sir. Stephen, lift your arm for me. Try to lift your arm. Do this for me. Can you move this leg for me, sir? Can you lift your leg for me? Oh, good. Excellent. Well done. Okay. Can I see your other hand, sir? Can I see if you can move this hand for me? Squeeze. Give me a squeeze. Try to move your fingers. Give me a squeeze. Good. Try to move your leg. Wriggle your toes for me, sir. Try to bend your legs for me. Very good, sir. Well done. You don't see that often, that, patients moving, they're trying to move their leg immediately after such a big stroke. At least we've seen some improvement, now. I'll see you later, sir, okay? Stephen, I'm going to see you later, okay? Live in peace now, I think.
Senior Doctor Teresos, please. We have a standby. Senior Doctor Teresos.
Just coming off the junction now, guys.
Checking that we've got blood cardiothoracics on site.
You're there, she's fine, she's a bit tearful. An airway obstruction. And how long after eating?
Okay, so this is the 27-year-old who was admitted to us a couple of days ago with the open head wound and neck injury following a machete attack.
So we did an EEG yesterday, didn't we? Can we just have a quick look on the report, please?
Yeah.
We had the police come round to us. It was about midnight. We've got a bit of bad news for you. Your son David's been assaulted. He's having surgery and then he's going to critical care. And as soon as they said he was going to critical care, I knew it was serious.
The EEG doesn't show any evidence of epileptic activity currently.
It's certainly a very severe life-threatening injury, and the survival of David at this point is not sure. Shall we slowly start reducing sedation and see what happens?
Hello, sweetheart. David has a learning disability and he also has schizophrenia. People with schizophrenia can be misunderstood. It's very rare that you get someone with schizophrenia who just goes out attacking people. David would hear voices, he would have hallucinations, but we knew when this was happening to him because he'd put headphones on and he'd play music really loudly to drown out the voices.
The first 7 to 10 days are critical and anything can happen at any time. And even if he survives, it's very uncertain how much neurological recovery he will make.
If people look past the disability, he's like a child in an adult's body and he just wants to be loved and he wants to be normal. Is he doing okay?
No, he's doing fine, yeah.
To see him like that's horrible. I never in a million years thought that I would be that mum. Being told that my son's life hangs in the balance now and it's up to him to fight.
Could do with some beds, really. I've moved one lady out.
Good morning, Stoke Recess.
Trauma time.
I had a feeling about it.
Sounds bad.
Thanks. Bye. 35-year-old head-on collision at 9 o'clock this morning. 2 cars, unknown speed. Environmental entrapment for 30 minutes. Chest wall head injuries. Ob's now stable. Hemodynamic stable, had 1 gram of TXA and has a pelvic binder on.
Let's get the trauma call out. Clear recess 1, get the trauma call out and we'll go.
Put the helicopter lights on. It's trauma alert.
We've got an emergency coming in that's going to delay.
Adult male.
Being able to come. It's an absolute emergency.
Head-on collision. Chest wall injury. Head injury. Okay, cheers, thank you, bye.
So we're expecting to have pretty nasty head injuries, reduced consciousness, and hopefully his chest, not too bad, but if he's been trapped, there's quite high likelihood of injuries.
In a major trauma, you just don't have that time to sit down and work out what's going on. You've got minutes to make the right decision. Whatever's happened to them has happened in a split second. Their life could be in a race against time.
What time's the trauma arriving?
1 minute.
The moment a patient crosses our threshold, you're fighting a clock that you just want to pause so you can find out what's going on.
Okay. Happy? Stable? So we'll get him transferred, then we'll all have a listen.
Ready, steady, move. This is Adam, head on, about 50-mile-an-hour road. Evidence of a head injury with reduced GCS, laceration to the chin and the vertex. Intubated, ventilated to an end tidal of around 4. Dressings and a nightingale to his chest wound. Immobilisation, pelvic binder, a gram of TXA and 1 IV access in his left ACF.
Brilliant, thank you very much. We get him on our monitor, get him exposed and start a primary survey. Chris, airway, you happy with the airway? Yeah, you're happy? Great.
Ventilator.
So there is an anterior chest wound over medial clavicle, which I can feel a step in. There is ooze coming from it, but appears to be no bubbling or sucking. There are some abrasions over the lower chest wall. There's a palpable radial on the left.
We'll get him off the scoop, we'll x-ray, get him warmed up and get him through the scanner. Scanner ready.
Okay, so you can feel clavicles deformed. From there, there's a big step there. All right. I'll go around CT. Intubated ventilator, Saj. So I need your portable oxygen. CT's ready, we can go straight in.
It's low, isn't it?
It's his head that we're really worried about. Great. And that chest wound's interesting because there's quite a lot of blood vessels under there. Yeah. He could have caught one of those and that could be bleeding into his chest that we can't see. But if he's hit the car going 50 the other way...
Combined 100.
There's something going on with him. You're not unconscious when the crew arrive for no reason, so... There's a little bit of blood, but nothing dramatic. So we're pretty happy there's nothing catastrophic going on from a bleeding point of view. couple of stitches to his head. He's got a fracture of his collarbone. Open fractures are really dangerous because there's a high risk of infection, so we want that treated as soon as possible, really. I want to take him to theatre, go and clean that all out. Safest thing to do is keep him asleep, do the operation, and then wake him up. He's lucky. His life, for a split second, was threatened. We know that car accidents, that rapid deceleration, or where all your organs keep moving, can be one of the main causes of death. It could have been so different. You could have been the person breaking the news, but they didn't survive.
Hello, Royal Soap Resource.
2 porters to resource, please.
Richard, we're going to be struggling again for space. I don't know what time the one that Ed's got head injury, black eye, epistaxis.
Chest and back injuries.
There's a gentleman possibly having a heart attack. We got any notes? Where is he?
Hey, he's in cubicle 2.
Cubicle 2.
Alright. Just keep taking those nice deep breaths. I'm just going to sort you out with some pain relief, okay?
Okay.
Did the paramedics bring you in?
No.
No?
Wife.
So you've not had any aspirin or anything like that? Okay, alright.
Hello there.
How'd you do?
Hi, I'm Vin, one of the cardiology fellows. Nice
Hello.
to meet you.
Nice to meet you.
So, when was your worst pain, sir?
I'd say about 8:30 it started, and it just gradually got worse and it didn't go away.
How old are you, sir?
50.
You smoke?
I do, yes.
Okay.
Been away, haven't we? We went to Salou and you just thought as it
Came
was
back on Saturday, I thought it was acid.
with the lager and you know what I mean? Just cheap lager. So he's just been taking Gaviscon and hoping as it's just like trap wind.
And it's been okay. But
Yeah.
you just know in yourself something's not right.
One side of the heart is not getting enough blood supply.
Okay.
You're having a heart attack. So we need to get you fixed. So we need to bring you into cardiology and then get you in our cath lab today to do what's called an angiogram, okay? If there's any blockages or narrowings, that they can do something there and then, and they will do, which will make this pain go away.
Well, to be quite honest, at the age of 50, you don't think somebody's going to have a heart attack, do you? It's hard for take it all in.
Bed 3. All right, we'll be up shortly. Thanks, bye, bye-bye. It is an emergency. We need to get the artery open as soon as possible to get the blood flow back to the heart to prevent any further damage. So we need to act quickly. Oh, the lab's ready? Oh, right, okay.
Celebrity.
I've got it wait for now.
He's in the process of having a full-blown heart attack, but we're going to change that.
Okay, thank you.
So a little jiggle and it'll take it in. Little jiggle. So right foreguide is fine.
There's the blockage there.
So Richard, we expected to find a blocked artery. We found exactly that. We're going to open that up now.
Okay.
We gave 6.5 of heparin.
When the vessel's blocked, you really have to get the blood supply restored in order to prevent damage to the heart. The legacy of each minute, or 10 minutes or 15 minutes, then manifests itself later down the line. The main issue would be scar forming on the blood vessel, but you could also have cardiac arrest, heart failure, recurrent angina in the days and weeks to follow. So the quicker we get there, the better. Just turn the tip of the wire downwards. There you go. So the blood supply's back. We're gonna... You relax. Okay, it's really important. Just breathe normally. If you overbreathe, it aggravates the pain. There we go, well done. And it's going to get better and better and better as we just relax. Now we're going to put in our stent. You feeling a bit more comfy?
Yeah, it's not cold.
Won't take us too long. It'll be another 5 minutes or so.
Okay, thank you.
What this is a very cleverly engineered spring. The idea being that it's mounted onto a balloon, and when the balloon inflates it, it'll open up as a scaffolding which then does not collapse down. And what Sherb and Vinny are going to do is they're going to position it. They can see on the screen where it is. The stent is on the balloon between the 2 dots. Okay, so it's going to be pretty
Breath
mobile.
in and hold or something?
No. If you go up to 1, actually go up to 2 atmospheres, and don't come down from there. That's absolutely bang on the money. Stay there, looks great. Richard, we're just squeezing in our little stent into the artery. Maybe a little uncomfortable for a couple of seconds. Down at 30. Heart rate's better, blood pressure's good, patient's comfortable. You've now got this rather beautiful artery which has been restored, which is there to supply the bottom of the heart. The blood supply is completely back to normal. We're looking at the ECG, which is normal. Great. All sorted?
But overwhelming. I think it's just the emotional bit now, isn't it? Wife, daughter and my dad. They're everything, really.
Probably try and keep that
Good morning, sir. You seem to be a bit awake. Moving his eyes.
He is. He's starting to look at us now when
I know.
we talk to him. Yesterday afternoon, David started opening his eyes. David, that's it. Good boy, David. Well done. He's much more awake today. And so I'm just hoping each day he gets a little better each day.
Right, sir. I'm just going to have a quick visit to your chest, if that's okay, sir. That's good. Add entry. One second. Is there any secretions, Mo? Is there any secretions from the chest point?
Secretions is the minimum.
Minimal secretions. Are they creamy or? Okay. That seems to be a good improvement from what it was yesterday today, isn't it? That's kind of
We know that maybe we're going to be saying goodbye to the old David, but it's just a case now of welcoming in the new David.
I think I'll strongly encourage you to keep speaking to him and bring some pictures of the family. Does he like anything like a music or?
He loves music.
Okay. He's young, so therefore his recovery from the organ systems may be good. But what I can't really say now at this point of time is how long will the brain recovery take and how much recovery would he have. Unfortunately, it's a waiting game, I'm afraid. But to be fair, if you ask me, am I happy with the progress? Yes, I am.
Yeah. Thank you.
Okay.
Yeah, and thank you for what you've
No problem.
done for me.
This is the standby phone for resus for our very sick patients that come into the resuscitation area. If you phone the main switch...
Pretty much everything we operate with is a limited resource. Time is one of those as well.
Her right leg is healing.
That's the job, is to work within that limited time frame with the sickest patients.
Ben, are you ready for RSI need?
Hello, resuscitate, Tina speaking. It's at 15 litres.
Right, what have we got?
A guy who's been working under a car.
Yep.
The engine has fallen onto him.
Let's get a kit open and have a scalpel ready. Let's get ready to put holes in both sides of his chest if we need to, please.
Yeah.
Lovely. Patient has arrived, so let's get ready, please.